Good morning, everyone, to Stanford Medicine's virtual town hall on COVID-19, number 11. My name is Andra Blomkalns. I'm the chair of emergency medicine. Thank you so much for joining us today. Last week, we got to see just a taste of what Stanford Medicine scientists and researchers have been doing since the epidemic started. Today, we're going to continue on that in terms of what we've learned and what that means for Stanford Medicine moving forward. Today, I'm honored to be joined once again by Stanford Medicine leadership and 4 new panelists today who will be each giving a presentation. Tom, why don't you get us started with introductions?
Thank you. Good morning. My name's Tom Montine. I'm chair of the Department of Pathology.
Good morning. I'm Melissa Bondy, and I'm chair of the Department of Epidemiology and Population Health.
I'm Rusty Hoffman. I'm Professor-in-Chief of Interventional Radiology and Medical Director of Digital Healthcare Integration.
Good morning. My name is Josh Salomon. I'm a Professor of Medicine in the Department of Medicine in the Center for Health Policy.
And at this time, we'll turn it over to our Stanford Medicine leadership for opening remarks.
Thank you, Andra. Good morning, everyone. Thank you so much for joining us here today for another edition of our COVID-19 town hall meetings. I want to begin, just as we've begun every meeting, really by thanking you for the amazing work you continue to do, for your dedication. We are beginning to see the light at the end of the tunnel in terms of, as you'll hear about today, some of the things we need to know and then implement in order to recover, restore, and reopen, the R3 that we've talked about here before. The faculty you're going to hear from today are, each of them is doing transformative work in looking at the type of data that will drive decisions both by our local, regional, national officials, and also by the leadership and by you in terms of what we can safely do to restore towards more normal activities. We've been in shelter in place for a long time, but we know that it was going into shelter in place and continuing to observe the guidelines around social distancing that has really enabled us to lower the incidence of new cases of COVID-19 in our region and to enable our healthcare delivery system to provide the type of outstanding care that patients who have COVID-19 so desperately need to receive. And we want to make sure that that's the case moving forward in the future. Again, thank you very much for all that you're doing. We look forward to staying connected through these town hall meetings. And let me turn it over now to Paul King.
Thank you, Lloyd, and good morning to everyone. As Lloyd was saying before, recover, restore, and reopen. I was reminded of a quote I heard from a colleague on the East Coast. In healthcare, we really never closed. We've always been here for those who needed us most, while we make room for those who might need us soon. And as we think about standing down our capacity, we reported to you in previous meetings the significant drop we saw in our volumes. We were pleased to report after 2 weeks of gradually recovering and restoring, on the children's side at least, in surgery we see about 85% of our cases have already returned, which is great. On the inpatient side, that's about 70%. In our clinics, we see more volume coming back through our specialty clinics at around 80%, and our primary care clinics are still a little slow in getting back at around 40%. These recovery efforts would not be possible without the work that you're doing each and every single day. We'd like to call out specifically our staff in our clinics, our surgical schedulers, all of our clinic staff, and certainly all of our hospital employees who are here when those patients return to us. Thank you for all you do. David.
Thank you, Paul and Lloyd. I appreciate all the great work that's being done, and I just would like to reiterate that. We want to say thank you, and we don't have the opportunity to say that enough, and we appreciate everything you're doing every day. I also want to share, about 2 weeks ago when we talked about opening up elective procedures, much like what we're seeing at the Children's Hospital, it's exciting to see what's happening within the adult hospital too. We typically will run between about 12 to 1,400 cases on a weekly basis. The first week back, we hit almost 900. And in the second week, we did hit 1,200. So think about that. We were able to move quickly to be able to make the capacity, as Paul shared, and that was important because of what we thought was going to happen. But now I'm impressed with what the teams are being able to do to help restore what is very needed for our patients in their care. We're seeing almost a little bit over 70% of the patients coming into our outpatient clinics We're at about 75% if you look at the hospital beds that are utilized. Still, there's capacity there. And we're approaching close to 60% when you look at the emergency room. Certainly that's something that as we see, and we've sent some specific marketing materials trying to encourage folks, because we know that there's still reluctance of individuals to come back in. We want them to know that it's a safe place to be and they shouldn't delay the care that they're getting. But we're so proud of what you're doing. Thank you for the continued efforts that you have to make sure that our patients are kept safe every day and are getting the care that they need. Andra, back to you.
All right, thank you so much. So now we'll have brief presentations from each of our panelists. Our first presentation will be by Rusty Hofmann from the Department of Radiology.
Thanks, Andra. Rusty Hofmann. I'd like to talk to you a bit about an effort that I've been part of in representing really the collective work of a partnership between the School of Medicine and Stanford Healthcare. Really appreciate the support from David Entwistle and Topher Sharp on the hospital side, and Dean Miner and Michael Halas in order to make what was an idea on March 17th be deployed nationally on April 1st. So 14 days. It's remarkable how quickly this went. Let me tell you what I did and why I did it. So I'm the medical director of the cath lab as well, and I was worried, how am I going to protect my patients, my faculty, and my staff? And it was a lack of data. We had no testing data. There was only 35,000 people in the country that had been tested at that time. And I was worried about a surge that was going to hit, and we were going to be unprepared. So if you really look at the way this virus behaves, someone gets infected. They hang out for 3 to 5 days asymptomatic before they start to have symptoms. Then they're like, am I sick? I'm not sure if I'm sick. Then they decide, maybe I'll go see a doctor. They then decide to go see a doctor. The doctor says, hey, let's go test you. Then they actually have to drive someplace, get a swab put into their nose and pulled out, and then tested, which takes another day or two to get that back. So from when they have symptoms until the test comes back is about 7 days. The problem is, from when you have symptoms till you're hospitalized is 10 days, all right? And we know that 20% of patients that get infected end up in the hospital. So we've lost 7 days of time. So what if we were able to actually detect the symptoms at the time of onset? And that's where this concept of a digital swab comes in. We have patients and people in the community responding every single day. Do they feel well or unwell? And as soon as we start seeing people that felt healthy to people that felt sick, as that starts to change, we can say the virus is on the move. Maybe we need to do some targeted testing in that area. Maybe we need to inform public health officials. So this really is, the digital swab idea is really something at a population level that by monitoring this data we can understand where the virus is going. Whereas the physical swab is something that's a single point in time on an individual. Both are important. So what is this tool? It's called the National Daily Health Survey. It takes about 1 to 2 minutes to fill out initially, and it's basic demographic information with zip code, age, gender, and then you report whether or not you're having symptoms. You have the option to put in your email and in about a week your cell phone number, and we can send you daily reminders to report in. And the reporting part on a daily basis takes about 10 seconds, maybe 30 seconds. We're implementing a few more questions to find out who's being tested and what type of test they had. So it's something that I really am appealing to everyone in the country to do your civic duty. Everybody wants to do something to fight this virus. Here's something you can do very, very simply, very easy, in the comfort of your own home, even in your pajamas. So here's the strategy that I think is going to be a winning strategy, is that it's really a three-pronged approach to tracking the virus. You have the National Daily Health Survey, which is something that can scan across the country. It's very low friction, easily adoptable, easily scalable, very low cost. Then identify where people need to have physical swabs done in order to see if they're positive, and then implement contact tracing. So here's some data on exactly what we've accomplished so far. This launched on April 1st. We just yesterday passed through 2 million visits to the site, and we have people engaging on a daily basis. When we launched this, we broke our Google instance twice. because this was more sticky of an interaction than anything that actually had ever been launched before. And so what it shows is a couple of things. People will do it, and they will continue to do it. The graph on the bottom left is actually showing nationally over time how the number of symptoms have decreased at a national level. The heat map to the right side just really shows where we have the uptake. So obviously in California, we have a pretty good uptake, but we are getting significant data from all 50 states. And so my ask to everyone that's watching this is to go to the link, sign up for it, and then push it out across all your social media platforms if possible. All right, thank you.
Excellent. You had me at making a contribution in pajamas. That was a key, excellent. Our next presentation will be by Tom Montine, the Department Chair of Pathology.
Thank you, Andra. Thank you for the invitation. I would like to speak with you today about clinical testing for the SARS-CoV-2 virus. As Rusty just said, there are many tools that we'll bring to bear to fight this virus, and one of them will be testing. I'm showing you two images here. The cartoon on the right is a representation of the structure of the virus and its different components. And at the bottom, you see the interaction between the virus spike protein and the host receptor. That's key to infectivity, and we'll come back to that in a moment. The image to the left is the atomic resolution. That's a real image of the virus, the atomic resolution image. And in green is the receptor binding domain, the part of the virus that binds to that host receptor, and again is key to infection. So the way we can detect the virus or consequences of the virus are either directly or indirectly. The direct detection of the virus has three techniques that we can use in the laboratory. One is to isolate the virus itself. That's very laborious and requires highly specialized rooms and equipment. So we don't do that. In fact, I'm unaware of any clinical lab in the country that uses that technique. The second is to detect the virus genome. The third is to detect virus antigen. The technique that we use in our laboratory is a very sensitive PCR. That's a way of amplifying nucleic acid sequences, and we use that to detect the virus genome. In addition to detecting the virus or parts of the virus directly, we can determine the consequences of having been infected by the virus, specifically that someone mounts an immune response, and that typically involves the elaboration of antibodies that are called immunoglobulins. So IgM is one type of antibody pictured there, and IgG is another type of antibody. And they're important to distinguish because neutralizing antibodies typically are IgG. So what we've accomplished in the laboratory over the last several months, thanks to the foresight of Ben Pinsky, Stanford was either the first or among the very first in the nation to launch a PCR assay in the clinical lab. We did that on March 4th. And since then, we've run over 54,000 PCR assays to detect virus in patients at Stanford and throughout Northern California. 1 month later, on April 7th, we launched the serology assays. That's the term we use for measuring these antibodies in blood. Since April 7th, we've run over 16,000 serology assays detecting IgG and IgM. Again, mostly for patients at Stanford, but also supporting our colleagues throughout Northern California and other parts of the United States. I wanted to give you an idea of what we plan to do next. So I've put here a timeline from January of 2020 out to 2021 and beyond. So our three goals are to innovate, prepare for what's next, and then anticipate as best we can what might be the next pandemic. So for innovation, I already talked to you about the PCR assay that Ben's lab began developing in January, and then we launched in early March. The serology assays that we began developing in March and launched in early April. And once we had the ability to detect antibodies in blood, that gave us the ability to begin to collect convalescent plasma, meaning people who have been infected donate blood, and that is potentially therapeutic either in compassionate use or in a clinical trial that now has just been funded. Our next steps in innovation are to develop tests for not simply antibodies, but antibodies that block the interaction between the virus and the host cell receptor, so antibodies that lower infection or your risk of being infected, and then a specific type of PCR that would focus on not just simply the presence of virus, but the presence of a productive infection. We intend to prepare for the possibility that next winter there might be another wave of infected individuals, so we intend to grow our capacity 5 to 10-fold over what it is currently. And then we hope to launch sometime later this year or early next year a panel of broad PCRs that will allow us to surveil for nasty viruses that are transmitted person to person to be prepared for the next pandemic. While I have just a few seconds, then I would like to thank for the invitation. Also to give, I'm very proud and grateful to the scientists, staff, and physicians who are in the Stanford laboratory, and then a list of our collaborators. So thank you very much.
Thank you so much, Tom. I know that fateful March 4th was a game changer in terms of being, on the clinical front, of actually having a tool to find this enemy. So thank you to you and your department and all your scientists. All right, our next presentation will be by Josh Salomon from the Department of Medicine. Josh.
Thank you, Andra. It's really a pleasure to be here today. Since March, I've been involved in a number of COVID-related projects in collaboration with teams of students, fellows, and faculty from Stanford as well as from other institutions. And we've been using epidemiologic and policy models to help decision makers at Stanford Healthcare and in Santa Clara County, as well as in other cities and states and countries, to try to mount and plan an effective COVID response. And so I'd like to talk to you today about some work that we've been doing to look at the question of how we can use contact tracing effectively as we continue the reopening that's going on around the country. So we've been hearing a lot about contact tracing recently. Contact tracing is good old-fashioned public health, and it's used effectively in disease control and outbreak response, and it's been used for decades. So contact tracing means identifying cases who are infected, learning about all their contacts, reaching out to all of those contacts, letting them know that they've been exposed, and then supporting them to seek testing, to monitor for symptoms, and to self-quarantine and isolate. And if you look at places that have been very successful in containing COVID, from South Korea to Germany, they've all been places that have mounted very aggressive and very effective contact tracing programs. And so we wanted to ask how contact tracing programs could be designed for maximum impact, and to what extent effective contact tracing would allow us to ease, at least partially, physical distancing measures that we've been under. So we did this by developing a relatively simple model that represents the epidemic as a branching process. So generations of infection depend on whether a person has symptoms, whether they're detected, and whether they're the contact of a known case. And we use this model to look at a range of different scenarios to ask what are the conditions, what are the design features, and what are other uncertainties that can drive the impact of contact tracing strategies. And then we can summarize them in terms of the reductions in R, which is the average number of secondary infections that each infected person causes. And a graph like this can give us a look into the contours of effectiveness in relation to various different factors. And I'm just going to summarize a few of these quickly here. So the first is that without adequate testing in the community, there's a very low ceiling on how much impact a contact tracing program can produce. The second important driver is the level of isolation and quarantine efficacy. And that requires that we can promptly identify cases and contacts, and that we can achieve high levels of adherence to quarantine and efficacy. And here you can see if we can achieve moderate levels at least, we might expect contact tracing programs to reduce transmission by 20 or 30%. The third driver is a policy choice, and that is to test all close contacts of known cases rather than only those with symptoms, which has been the recommendation until very recently. And so you put all of these things together, high levels of testing in the community, good tracing, prompt detection, high levels of adherence, and testing all contacts, and you can start to develop a program that might reduce overall transmission by as much as half. And that's actually a really big impact, and one that we don't see in many other interventions that we have. And to think about the implications of that, what that means is that contact tracing, if done effectively, really could provide us some headroom to start to ease some of the strong physical distancing and public health orders that are in place. And the translation is roughly, if you have a contact tracing program that reduces transmission by about 40 or 50%, you're able to start to peel back other restrictive measures by almost the same amount. And so think of that as returning to about half of the levels of interaction and activity that we were at before lockdown. And so we've been discussing this analysis and sharing this model in the form of an interactive tool with decision makers in health departments and governments. And there's quite a lot of interest in these questions. And so the bottom line, as I would put it, is this. Contact tracing doesn't need to be perfect in order to make a big impact. And contact tracing programs, while they're not going to replace strict lockdown, really can start to give us quite a lot of runway so that we can begin to reopen the economy safely. And so we hope that this tool can be useful for decision makers as they plan a response and they try to design a contact tracing program for impact. And finally, as they try to benchmark the performance of that program in terms of what ultimately matters, which is reducing transmission and improving public health. Thank you very much.
Thank you so much. And now, Melissa Bondy.
Thank you. And I want to thank both Tom and Josh for really setting me up for the work that we're going to do. As a new Department of Epidemiology and Population Health, it was really our goal to step up to the plate with all of the amazing work that's being done in our department to really put the research that's being done here and within our own department out into the public. So I want to talk about a couple of projects that are ready to go live, and one of them is being conducted by Julie Parsonette and Jason Andrews with some funding from CZI and also working collaboratively with the Stanford Medicine group, Gauss Surgical, who's helped develop some of the apps that are going to be used and other tools for this study, and also Santa Clara Public Health Department. We've been working closely with them and Solano Public Health. So our goal is to estimate the seroprevalence, and thank you, Tom, for explaining all of what we're trying to do. We're first going to be using a very strict population methodology, and to be able to launch this study both in Santa Clara and Solano counties. We'll be taking random samples of county residents, also including some prison populations, first responders, and our goal is to recruit about 15,000 people, and this is scalable not just to counties surrounding us in the Bay Area, but also other counties as well. We're using a very rigorous, unbiased sample of populations, pairing in-home collection and blood with online surveys so that we can really make sure that the assays we're doing are appropriate. So they're going to be sent out. We've developed, Julie has developed these nice boxes that will be sent out to the participants. And this is just an example of how it is. It's that we have videos that are already incorporated into the kits, and so that online, so that they would be able to collect the data in their home and send it back with these in completing online surveys. So this project is ready to go live, as well as others that we're working on. So I would like to tell you a little bit about some of the other projects, and these are just a few. I have 5 minutes. And so we wanted to talk about other enhancing public health data ecosystems that Dr. Lori Nelson is working on. And we're building integrated geospatial data ecosystems to examine geographic clusters and of unequal burden of COVID-19, looking at how the virus could be spreading in populations, looking at household crowding, social determinants of health, and also we're going to begin this study in Solano County as a demonstration, and it's also scalable to 8 of all 58 counties. Well, this will enable the health systems, the agencies, to have dashboards that we're able to build, and we're really working closely with the counties to be able to launch this in a way that would be appropriate for them to map out and to see what's going on in each of these counties, to predict future outbreaks, just like Josh was talking about and others, so that we can monitor this over time. We've received some funds from different sources, and we're working very closely with Google Cloud engineers to really build this up and make it scalable, and they've been very supportive and having very frequent meetings to get this going. Another thing that we're doing, which is being headed by Dr. Lori Nelson, is contact tracing, and we're putting this into place using, it's an opt-in approach, and we're using Google geolocation history that will really significantly help us to identify the populations through contact tracing that can help public health staff and the contact tracers that are out in the field. These are demonstration projects, working with local communities so that we can easily scale these up to larger populations to be able to have very efficient ways of identifying the contacts that need to be traced. The last thing I want to talk about, we have a lot of other projects that we're doing in epidemiology, but this afternoon I want to give a shout out to Dr. Lisa Goldman Roses, who is sponsoring a virtual town hall to the community. Last one, this is our second. The last one we had over 2,000 people come, and this is very appropriate for today. How does the new normal look like in healthcare, education, and the workplace? If you go onto the website of Stanford Medicine, Community Outreach and Engagement, COE, you'll find the link to register, and I know that this is going to be a really important and engaging town hall. I want to thank everybody for inviting me and including me today, and we'll be happy to talk about these projects as they go live and we have data to present. Thank you.
Thank you so much. So now we'll move towards our pre-submitted questions. Melissa, the first question is for you. Are you collecting any user data on the impact of COVID-19 that you can say something about what is happening with specific age groups and ethnicities, and what does that mean?
I think some of the projects that we are working on, so the Apollo survey that is being mentioned to us, we are collecting survey data in populations. We've been working with a couple of counties right now, in particular where they are being tested, so we can link the testing with the data that they provide to us about their concerns about COVID, including some of their symptom information, and we are gaining information on large numbers from around the county, around the country, specifically in county areas where we can look at these age groups and ethnicities. But of course, the other two projects I told you about are also, the methodology includes really making sure that we have the appropriate age groups and ethnicities are included in those studies.
Great. Thank you so much. Tom, how effective has convalescent plasma been in treating COVID-19, and what is Stanford doing to get a stockpile of it?
Thank you for the question. So a patient is convalescing if they have been infected and recovered, and some of those individuals agree to donate their blood in the hope that it can be therapeutic because it contains antibodies directed to the virus that they were previously infected with. Convalescent plasma has been used in medicine for over 100 years. There's strong anecdotal evidence that it can be effective, but there's really very little, if any, robust clinical trial evidence that convalescent plasma is effective. So what we've done here, now that we can measure antibodies in blood, we have the blood center, Stanford Blood Center, has been asking for volunteers to donate blood if they've been infected. Currently, there are, as of last week, a stockpile of 70 convalescent plasma donations, and 60 doses have been distributed throughout California and other states for compassionate use, meaning someone was very sick, and so in the hope that it might help, convalescent plasma was administered. Multiple faculty at Stanford in pathology, but also medicine and other departments have joined a national effort to launch a clinical trial to assess the efficacy of convalescent plasma to COVID-19.
Okay, great. Rusty, how is it determined that only 4% of a population is considered a representative sample, and what are some early learnings from that?
Great question, Andra. So it's funny that the interventional radiologist on the panel got asked this question with the thought leadership of health policy and epidemiologist on either side. But so this was the swag, our best guess based on discussions with Steve Goodman as we were spinning this up. Building this app and getting it launched was a bit like the analogy of jumping off a cliff, assembling an airplane and learning how to fly before you hit the ground. And so that's kind of where that number came from. The learnings that we have right now is really related to the technical stuff that's been deployed, that it's highly functional, highly engaging, and highly sticky. Now, and it also is tracking what we believe to be the trends over time, is the decrease in symptomatology. And Dr. Goodman's thoughts were that really the gold standard to validate this is really on hospitalization rates, because that's just biology. We believe about 20% of the people that get infected end up in the hospital. So there's no way to cheat the system, and that's a very hard endpoint. Whereas testing, a lot of that has to do with availability of testing and availability and willingness of the patient to go do it. So still more to come.
Okay, great. For me and maybe some of our viewers, can you help us understand what the word sticky means? Because it just sounds gross.
So sticky is a great question. Sticky is a term used in the tech world that you once you engage with something, it kind of sticks to you. Kind of like if you ever use it's like the pink tape in the hospital. Like anytime I use that, I end up kind of bound on myself and didn't get the pink tape on the patient.
All right, very good. Thank you for that. Josh, what does contact tracing at Stanford look like now, and is it being built up?
Yeah, thanks for the question. I've been mostly looking at contact tracing in the community, so I suspect that others, including David and Paul, may be better positioned than I am to answer this. But I do know that the role of occupational health and infection control in the hospitals is to ensure the safety of our healthcare workers. And I also know that there are processes in place so that when a healthcare worker is exposed, they access appropriate testing.
Okay, wonderful. Melissa, how will the data from Apollo be used to provide care for those most affected by COVID-19 once this pandemic has subsided?
So I'm going to move away from Apollo because that's another app that we're using in different counties with testing, both COVID testing and with seroprevalence in specific counties that we're providing this app to. But some of the really important work is the work that I mentioned that both Dr. Julie Parsonette and Lori Nelson are doing, where they're really trying to work specifically with counties so that we can follow patients or participants really over time to see if their seroprevalence has changed, because that's really important to see whether or not people are still, whether or not they have antibodies or not. And so we can follow them over time, as well as incorporate some of these things and this information back to all of us to understand what the prevalence of of these antibodies are in a population. So we're really looking forward to seeing those results and being able to see if there are changes over time, and we can see if people may have been exposed and we might have antibodies but never had developed COVID or a major problem with COVID. So I think these are the kinds of things that we're hoping to see, and incorporating in some of these other programs is the contact tracing, where we can work with counties and work with other population-based communities to be able to understand that in a way that we can intervene as necessary.
Great, thank you so much. Lloyd, we're all ready to get back to something called normal. When will the School of Medicine students be able to return to the hospitals, clinics, and labs?
Well, thank you, Andra. We'll have some students return to in-person clinical rotations next week, and we're anticipating resumption of full clinical rotations in the latter part of June, with a scale up along the way. Every student prior to going back into clinical care activities will be tested with the RT-PCR that Tom described just a moment ago in order to evaluate for the presence of the virus. Like the healthcare workers screening that we did with over 12,000 healthcare workers screened over the past several weeks, we're anticipating that it will be a very low positivity rate among the students, but we do want to do that prior to our students returning to the clinical care environment.
Great, thank you so much. Tom, everybody wants to know, when will we understand whether antibody signal portends immunity, and how do we go about answering that question?
Sure, thank you. So I think there are two parts to the answer to this question. The first is, if someone has been infected and they have a detectable antibody, so they're seropositive, they have had an immune response, right? A particular type of immune response, but that proves that they've had an immune response. I suspect what the questioner is asking is, how do we know that that immune response is protective from subsequent reinfection? And that's more complicated to answer. It requires detection of what's called neutralizing antibodies, meaning antibodies that will block that interaction between the viral receptor binding domain and the host receptor protein. So we're working hard on this in the laboratory. Scott Boyd and his team are developing a high throughput assay to detect blocking antibodies for that virus receptor interaction. And then Ben Pinsky and the team in the virology lab are developing a way to safely work with a modified virus to directly detect whether or not someone's plasma can inhibit infection of a mammalian cell. So those are coming.
Okay, great. David, considering what we've learned so far, what is Stanford doing to prepare for the second wave?
Well, if you think about, in essence, our ability to be able to respond is quite impressive. In fact, responding to these kind of situations is part of the cadence of what we're able to do. Now, we didn't anticipate that what was projected would be this large, and we had to do a lot to respond to that. But many of those resources are still in place. Should we get a second wave, should we need those additional resources, we still have units that would be able to be brought back up for inpatient use. We have now PPE, we have ventilators and other resources that are available. I'm so excited because of the great work that Tom talked about on the testing side to be able to quickly assess. So we feel as though we've learned a lot through going through this experience. We're learning as we go, and we'll be prepared as we see other surges potentially have the opportunity to come upon us.
Thank you. Rusty, how granular can your analyses get? And could the health surveys identify risks in particular neighborhoods?
Great question. That would be awesome if we can get to that level of granularity. really what we're struggling with right now is the way the data is actually reported out to us. As I said, our kind of gold standard or benchmarking is hospitalization rates. And those are actually kind of reported at the county level. And they're not reported on a day-by-day basis. It's just an average census. So you have to look for a change in the overall number of people that are in a hospital. So the data that we've looked at in Santa Clara County, we're starting to kind of unwind and untangle. But one of my hypotheses is we are seeing decrease in signal, and we saw decrease in hospitalization, but then there's an uptick in hospitalizations that it doesn't look like we are detecting. But much of the hospitalization and disease right now is in Southern County of Santa Clara, and Northern County is not as infected, but we're jamming all that stuff together. So now I have two great medical students, Anoop and Ankit, and then Mike Hittle from Epidemiology. What we're now trying to do is, like, if we can tie zip codes to the closest hospital and try and do an analysis at that level. But I think it's going to be really hard to get down to neighborhood levels, but zip codes would be the greatest resolution we'd be able to reach.
Okay, great. Paul, I mean, initially we didn't see effects of COVID-19 that much in the pediatric population, but recently the media has reported an alarming number of cases of pediatric multisystem inflammatory syndrome. Has Stanford Children's seen any of these cases?
Thank you, Andra. As you said before, we were sort of encouraged by the fact that kids hadn't been significantly impacted. With the benefit of hindsight, we now believe we had the first case of a child who had this inflammatory disease that we saw actually back in mid-March. This was a case that is now being written up for the medical literature. It was a partnership between our friends from Sutter Health, their Palo Alto Medical Foundation, working with Stanford Medicine faculty at Stanford Children's Health, where we had a 6-month-old child who did report with those symptoms. Last report, the kid's doing quite fine now, thank you. But now as we see those cases increasing on the East Coast, we have seen them sort of nationally and internationally, but thankfully we've not seen any additional cases here at Stanford.
Great. Josh, Apple and Google recently announced a digital contact tracing system. Is contact tracing something that can be done solely with technology?
Thanks, Andra. It's a great question, and I think technology certainly could have a role to play in helping health departments with contact tracing. I don't think technology is going to be able to substitute for the typical standard way that contact tracing is done. There's a lot of concerns about some of the app-based assistive technology for contact tracing, including concerns about adoption rates. They need to be pretty high for those to be effective, concerns about false positive signals, concerns about privacy that I think Apple and Google have been quite sensitive to, but may persist with some of the other technologies. But I think ultimately at the end of the day, contact tracing is fundamentally about human-to-human interaction. It requires between the community health worker and the client, a level of trust and empathy and rapport, and you just can't get that from an app. So I do think technology has a role to play, but I think it's not going to be a substitute for what is fundamentally a human enterprise.
Great, thank you. Next question is for me. You had mentioned that ED volumes had fallen across the country. What can you tell us about that trend, specifically as it relates to Stanford's operations? It's been interesting. Emergency department volume across the country has decreased as far as 40 to 50%, and currently we're in that 50 to 60% range. I will say that when I confer with my colleagues across the nation, that they're still dealing with COVID in a real way. I mean, there are even hospitals here in California that are full of patients who have this disease. So from an emergency medicine standpoint, I feel very, very lucky that we have the situation where we know we are safe, we know our healthcare workers are safe, and that we can provide a safe environment for emergencies, because there are a lot of places that aren't that lucky. Last question is for everyone. The first lockdown has been rather porous, yet very expensive. If we need to lock down again, how can we do it better next time? Tom.
My goodness. Well, I guess I would say my lockdown hasn't been very porous, but so I'm not exactly sure what the first part of the question means. doing it better the next time, I think through the apps and epidemiologic data, contact tracing efforts that we've heard about, we'll have more and better information to make decisions in real time. We didn't have that the first time.
I totally agree with you, and I think the work that we're doing now is going to put us into a great position that we're able to identify pockets of individuals that need to be locked down, and they're people that they may be infected, and the people around them, so that we can do a much better job.
Yeah, I think that perhaps something that will be of benefit is showing where lockdown was not porous and how effective that was in controlling the virus. And I think showing those success stories will be instrumental in the future if something like that should occur. Rusty?
One of my hypotheses has always been is that an engaged patient is a compliant patient. So I think if we give the people in the community tools to interact and feel like they have some type of control and are helping solve the situation, that will be an effective way to get them to comply.
Thanks. And I guess the penalty for going last is that I will largely just agree with my colleagues. But I think lockdown is a pretty blunt instrument. And next time we're aiming to impose restrictions in a more refined way and in a more effective way. And I think a big part of that is going to be that we continue to learn more and more about the virus every day, and we continue to address the weaknesses in information systems. And if we are better on both of those fronts, I think we can do a better job with lockdown next time.
Excellent, thank you. Well, thank you very much to Stanford Medicine leadership for joining us here today, and to Melissa, Rusty, Tom, and Josh for giving us your expertise. Thank you so much. Next week, we'll be changing some of the format of the town halls. It has certainly been my pleasure and honor to be with you as we've been disseminating this information. Our goal is to change the format a little bit to keep it engaging as we move forward with disseminating this important information. Thank you so much for joining us here today. Stay safe and have a great afternoon.